The major diagnostic categories within the heading of child and adolescent disorders include ADHD, or attention deficit hyperactivity disorder, ODD, or oppositional defiant disorder, conduct disorder, depression, bipolar, and DMD, or disruptive mood dysregulation disorder, and then the anxiety disorders, and autism spectrum disorder. Some of these are similar to the disorders that are seen in adults, but typically in children and adolescents, they may present themselves and the signs and symptoms a little bit differently. Child and adolescent psychiatric disorders typically result from a combination of circumstances that include family and genetics, or family genetics and biology, adverse family circumstances, which include divorce, inconsistent parenting, unsafe home environment, and maternal substance abuse, as well as comorbid health conditions. The word resistance, the idea behind that, has really come into play today. We see this hot topic in a lot of different areas, and resilience is defined as the concept of the ability to bounce back. It's why not all vulnerable children develop mental disorders. Some are said to be more resilient than others. Same thing we see in some of, if you think about your nursing student, fellow students, some students have really been through a lot, and so nursing school to them is not that stressful. They've developed some resilience through the things that they've experienced in their life. Other of your fellow nursing students may not be very resilient or have those techniques built up due to not having gone through maybe some things that have allowed them to develop some strong positive coping mechanisms. And so when we talk about resilience in children and adolescents with psychiatric disorders, it's typically those children that have that special quality that allows them to compensate and not go down the path towards mental illness. So again, resilience, the concept of why not all vulnerable children develop mental disorders. We think that some of them are more resilient or have, quote unquote, more resilience than others. And this is really kind of seen as having a more easygoing temperament. These kids with resilience probably have more supportive relationships, whether it's family, social circles in their church, or extended family members, those family resources that really kind of add to their sense of safety and security. And then the concept also of emotional intelligence. Are they keyed into their own feelings? Are they self-reflective? Or have they just really developed no insight into their own feelings? Childhood adversities can include parental adversities, such as parents who have mental illness themselves, addiction within the parents, or extended family members with whom the child lives, criminality within the parents, and physical or sexual abuse. There can be multiple hardships, so perhaps a parent who has mental illness also has addiction and is incarcerated. So the more risk factors that pile upon each other increase the risk for mental disorders within the child that experiences these hardships and traumas. And I think interesting studies have shown that LGBTQ plus parents, even though they may have experienced some adversities within society, they've been found that those children are at no greater risk for developing mental disorders than any other quote unquote normal male, female, mom, dad, family in society. So we're going to talk a little bit about ADHD, and it is the most common childhood psychiatric disorder in the U.S. 10.2% of all children aged 15 to 17 have been diagnosed with ADHD, and that's quite a bit. They believe that up to 74% of kids with ADHD have inherited this from their parents, and whether this is all genetic, all biological, I would think that probably some of that, because if their parent has ADHD, some of it is learned as well. So again, we always look at a combination of factors as possible causes. That's a pretty high number, 74% inherited. It is a complex brain disorder involving subtle changes. It's most likely a group of conditions, not just one single entity. There's 3 hallmark characteristics of ADHD, and they include a diminished attention span, hyperactivity, and impulsivity. So the attention span of the child is decreased. They're very hyperactive, and they have poor impulse control. Other frequent characteristics that can be seen with kids with ADHD include some other comorbid mental health conditions. Maybe the kids with ADHD might have depression or some oppositional defiant disorders. So we frequently see that. You don't have to have more mental health conditions with ADHD, but it is possible. And then these kiddos often have difficulty in school performance. They often have one or more learning disability. Maybe they have dyslexia. Maybe they have some other disability that keeps them from learning the way that quote-unquote normal kids learn. And a lot of times these kids with ADHD have enuresis. We've talked about this. We talked about that with the kiddos at the JSOP unit at St. Anthony. And we do know that enuresis is often seen in child and adolescent mental disorders. So when the kiddo is in the school system should be made aware of the diagnosis, and especially when the child is on medications that might make them sleepier, or when the child is not with a parent, and the child is kind of in the custody of the school system, and so the school system needs to know, for a variety of reasons. They can also provide extra assistance for these kiddos and give them modifications for homework and testing. Pharmacological treatment for ADHD kids includes stimulants. Stimulants, we know, in kiddos act the opposite way than they do in adults. So stimulants for treating ADHD would actually be focusing on decreasing the hyperactivity and helping the kiddo to focus. Those include these here. I'm not going to say their names. You know what they are from a drug brand name. Please learn these generic names. Okay, that will be how you'll be tested both in this class, throughout nursing school, and on boards. In addition to stimulants, there's the alpha-2 agonists, and those are the things that can be used for other medical reasons. The clonidine that we've seen here, the catapress, and then guanfacine or 10X as well. The next diagnosis that we're going to discuss is oppositional defiant disorder. It involves a pattern of the following mood symptoms. So we're going to see these kiddos losing their temper often. They're touchy, they're uneasy. If you touch them, they become uneasy. They're often angry and resentful, frequently argumentative. They're defiant. They argue with adults. They actively defy or refuse to comply with rules and authority figures. They are often deliberately annoying to others. They know they're being annoying. They enjoy being annoying. And it really is much more than just kind of teasing or playing around. It's to the point where it becomes a true discipline problem. They tend to blame others for their own mistakes, their misbehavior. They become vindictive, spiteful, and it really, these things you will see in a child who has this diagnosis more frequently with all of or a lot of these symptoms together, and it's a pattern of behavior that has happened at least twice in the past 6 months that causes a problem. The next diagnosis we'll discuss is conduct disorder. These kiddos have been found to be aggressive towards people or animals. And again, this is beyond what is acceptable, beyond what is, normal learning of boundaries. The boundaries have been explained, the boundaries are known, and these kiddos go beyond it, regardless of consequences, regardless of what other people feel or the ramifications from their behavior. So they're aggressive towards people or animals. And again, think about this to the next level, to where it's a problem, to where it's beyond what is tolerable. So it's excessive bullying, excessive fighting, used a weapon that has caused harm, especially when it's a younger child who seeks out access to a weapon, maybe a gun, maybe a knife. Maybe a knife has been found in the backpack at school. They're cruel to their family, cruel to animals. And then a lot of these kiddos that we see in our JSOP unit have conduct disorders, and because they're there because they've forced a sexual act on someone else. Remember, the sexual act, when it's rape, is not done as a sexual pleasurable act. It is for control and humiliation and degradation. Again, in these kiddos, you're going to see destruction of property, deliberately setting a fire with intent to cause serious damage, deliberate destruction of property not involving the use of a fire, maybe keying a car, slashing tires, trashing a house, those type of things. But the intent is to cause serious damage. Kiddos with conduct disorder are deceitful. They may steal. They can break into other people's homes or buildings or cars. They're manipulative. They lie to obtain what they want, favors. They avoid their obligations. If they say they're going to do something, they don't follow through on it. And again, this is more than just a little bit of kids being kids. It's to the point where there's a problem. They've stolen items of non-trivial value. They take it because they just want it. It's not a big deal, but they take it because they can. Also, these kiddos can have serious violation of the rules. Maybe they're staying out all night despite parental prohibition, and it's more than the kids sneaking out at night or at 16 or 17 years old. It's 13 years old, staying out all night, not knowing where your child is, running the streets at 12. Maybe they've run away. These kiddos have run away from home at least twice, because if you only do it once, usually that means if you don't ever do it again, you've learned your lesson. If it's more than once they run away, then that becomes a pattern of behavior, especially if the consequences don't make a difference or a change in their behavior, or if they've only run away once but it was for a long period of time. and that contact was not made with the parents. They're gone. No one knows where they are. That's just not normal behavior for a child who has an intimate bond with their family. And then these kiddos are often truant from school, especially beginning before the age of 13. So young kids skipping school. So children and adolescents who are diagnosed with depression can typically exhibit their behaviors differently from adults because they've not developed the words or the actions to express themselves the way that adults do. So they may exhibit feelings of helplessness and hopelessness as well, and some low energy level, but their social withdrawal, I mean, they have to go to school, right? So if they're not skipping school and they're there, maybe they're not participating in school. Maybe they are on the football team and they stop going to practice. So the social withdrawal might look a little bit different. They're also, especially in younger kids, more frequently irritable because not only are they frustrated and depressed, they don't have the words to express themselves. So that leaves them frustrated even more and irritable. And then depressed children and adolescents can also have suicidal ideations. Possible predisposing events for depression in children and adolescents include loss of parent through death, divorce, separation, death of an individual that was close to the child, death of a beloved pet, moving to another town or a neighborhood, changing schools, academic problems or academic failures, and significant physical illness or injury like cancer or things that make them change their lifestyle, give up things that they loved, or have to behave in a new or different way. Pharmacological treatment for depression in children and adolescents could include some antidepressives such as our fluoxetine. That has been approved for children 8 years old and up, as well as escitalopram, which has been approved for kiddos 12 years old and up. We know that antidepressives from our previous learnings have to be really closely monitored in children because of the risks involved for increasing suicidal ideation. Children who develop bipolar disorder are going to show signs and symptoms such as a mood instability, again, big highs and big lows. Kiddos that throw frequent temper tantrums that are no longer toddlers, that are older and still have those temper tantrums that you would have expected kids of that developmental age to have outgrown. Impulsivity issues, and then some subtle depressive symptoms. Disruptive mood dysregulation disorder really takes that bipolar and kind of turns it up to an 11. These are very, very, very irritable or angry kids. They're irritable and angry much of the day or nearly all of the time. They have severe recurrent temper tantrums and outbursts, becoming verbally and physically aggressive or violent. They don't really meet the criteria for depression or bipolar because of how severe their symptoms are. It really, again, if you know the symptoms for depression or bipolar, take those and amplify them, and that's how you get this. Look at the definition of the word disruptive, right? Disruptive mood, and it's dysregulated, it's unregulated. Disruptive mood dysregulation disorder. Anxiety disorders in children and adolescents, those can include the same as we've seen and talked about with adults. OCD, PTSD, separation anxiety disorder, social anxiety disorder, and panic disorder. OCD in children is pretty much the same as it is in adults with the signs and symptoms. So just kind of review what you know on OCD. They may exhibit perfectionism, intolerance of uncertainty, and an overestimation of threats, just because they don't have the frame of reference of long life and experience to know that things will have an end, that things may not be as bad as they seem, and so their ideas of threats may be even more blown out of proportion, leading to increased OCD tendencies. Again, PTSD, just review what you know about adults. Pretty much the same for kiddos. You're going to have them with nightmares, same intrusive type of memories, and they may be hyper vigilant about really focusing on things to the extent that so the trauma doesn't occur again. Again, their frame of reference to know a length of period of time of something is in existence, their frame of reference is different. So if someone's been through something traumatic over and over and they're an adult, they know that that has an end period, like the anxiety attack, right? We know that you've had this before. You will come down. I'm here with you. We're going to talk you through it. Kiddos that are having PTSD signs and symptoms may not realize they're having a nightmare, may not know that those intrusive memories will go away. So that kind of ratchets up their anxiety. Anxiety disorder, pharmacological treatment options, same as with our adults. Review these. It's going to be your SSRIs, your buspirone, and your duloxetine. Autism spectrum disorder is a persistent deficit in social communication and interaction. These kiddos have restricted, repetitive behaviors. Their interests and activities are going to be restricted. Their behaviors, their activities are repetitive. If you've not seen someone with autism, I suggest you go on the internet, find a valid website, maybe YouTube or an autism support group, and kind of look at those disorders and see what I'm talking about. If you have seen people with autism, then you know exactly what I'm saying. A lot of these symptoms are typically present in early childhood, and they can continue on. A person is not quote unquote cured from autism. So once they've been deemed to be somewhere on the autism spectrum, people can move back and forth depending on their anxiety and their stress levels, just with their behaviors. But again, autism is not something that we're going to recover from. It's not part of recovery. The symptoms do cause significant impairment in their social, occupational, and probably relational functioning within society. So it does have an impact, but again, it's not something that is going to be recovered from or cured. There are different severity levels with autism. Level 1 requires some support. Level 2 requires substantial support. And level 3 autism requires very substantial support. So if you want to know further in that what that means, you can look that up in your book in that chapter. But just know that there are 3 levels of autism, and depending on the severity of the autism, that's going to require, tell you how much support the child is going to require. Children on the autism spectrum can also have modifiers hooked onto their diagnosis dependent on severity and how it's played out and what is impaired. So these modifiers might include autism spectrum disorder with or without, let's say they have with intellectual impairment or without intellectual impairment, with language impairment or without. And then could be associated with a known medical or genetic condition. So it could be autism spectrum disorder level 1 associated with juvenile onset diabetes. It's not going to be with that, but with some certain medical or genetic condition. Maybe it's associated with Down syndrome. So you could see a diagnosis written out with the modifiers explaining what else is going on. It can also be associated with other neurodevelopmental, mental, or behavioral disorders. So some of the things that we've talked about in child and adolescent disorders, you can have multiple things going on. Pharmacological treatment for autism really depends on the symptoms, right? So maybe some antidepressants might help if they're socially withdrawn or isolated, or have low energy. Anti-manic drugs you might see if, again, depending on the symptoms. Anti-anxiety drugs, there's some alpha-2 antagonists or agonist stimulants, and then some atypical psychotics. There's just a little blurb in your book on child and adolescent pharmacological treatment options for the things we just discussed. Kind of look at those and understand. It's the same as what you've learned in adults, but I think that in the book it explains more why they use them for which thing. So the atypical antipsychotics for autism really kind of have evolved over the years, and now they're given these to kiddos as young as 5 or 6, and these include the generic Abilify, the generic Risperdal, some of the things that used to never be given to kiddos this young, but they've seen, depending on the signs or symptoms or the behaviors that they express, that this can have some effect in changing those behaviors and enriching the lives of these kids. So non-pharmacological alternatives used with these kiddos are, of course, me and milieu. So we ourselves as nurses want to provide a trusting relationship. We want to make sure that the family and the child feels safe and secure. If they're having some behavioral issues that lead them to seek inpatient treatment, they really need to make sure that their autistic needs are being met as far as them feeling safe and secure. Structure, boundaries, routine is important. And then for outpatient, there's definitely going to be a lot of education for the family, family therapy support groups, and then maybe some social work help on as the child gets older, and also involving the school. How are they going to maneuver through the system of the school? Can they work? What might that look like?